Okay, hello everyone. My name is Min Suk-soo, and I will make a presentation for today's lecture series. And I have noticed that many of our colleagues had or on having a great holiday for celebrating the end of the fest. So I also congratulate. And today, before starting, I would like to inform that if you have any questions or comments in between the lecture, please give me a comment through the chat or directly. And also, I apologize because I have changed our subject recently, but I think I would have liked to share some practical issues that we have when establishing the PRRT, like the radioligand therapy in our hospitals. Okay. Okay, so today's subject will be practical issues in establishing PRRT. So my subject will be dedicated to the more specifically to our establishment of the Lutathera therapy. However, we can discuss more about other therapeutic agents too. So firstly, this is currently our treatment status in Seoul National University Hospital. And we also do iodine therapy but and MIBG therapy, but additional to that, now we are establishing or doing ongoing clinical trials for lutetium dotatate, firstly for neuroendocrine tumor. And currently there are two drugs. First is Lutathera from Novartis, and this is a clinical trial drug which is made in Korea. And we have completed phase 1 clinical trial, and now we are using this for some compassionate use for patients who are not indicated to go through Lutathera therapies. And there is one another clinical trial we are doing using the Lutathera, and this is NETTER-2 multinational trial. So it is the proposed the study is to expand the indication of Lutathera to like higher grade advanced neuroendocrine tumors in more earlier phase more earlier phase. And next is about the PSMA targeted therapies. So we also have two right now, two drugs that are available, and both are under clinical trial. And first is a DOTA-GUL compound, which is made by Selvion in Korean, and we are ongoing for phase 2 clinical trial. And this is Novartis drug, the PSMA 617. We are under a multinational clinical trial of PSMA addition, which is for hormone sensitive prostate cancers. And I think in near future, we will also apply as a clinic for the PSMA 617 for castration-resistant prostate cancer patients. And we also are doing the yttrium-based radioembolization therapy for HCC and other liver metastatic cancers using both Therapir and Therapir. And we are also doing this radium therapy for prostate cancer patients with multiple bone metastasis. And this is some trend of our treatment status of the Lutathera. And we actually had the first case in 2019, October. And there was some growth in 2012 and 2021. However, now we are actually going into some steady phase. Actually, there was some hype initially because people in Korea couldn't have a chance to get neuroendocrine cancer patients in Korea did not have any chance of therapeutic options before 2019. And from the advance of this PRRT, there was an initial hype, and now I think we are going to go through a steady state of treatment. So currently, up to 2022 March, the total number of patients who had underwent Lutathera is 54 patients with a total of 161 cycles. And so as you can see, there are many patients who have ended up the 4 cycles of Lutathera. Actually, the currently starting, who have started the therapy from 2022 is relatively small, and 15 patients are undergoing therapy right now. So most of the patients are pancreatic neuroendocrine tumors, and the rectal NET follows it, and which also is followed by midgut. So this kind of epidemiology is quite different from other Western countries. So we have quite a lot of prevalence of rectal neuroendocrine tumors, which go on for the more distant metastasis. Okay, and this is a very preliminary pilot assessment of what is going on, what is the therapeutic efficacy of Lutathera therapy right now. So for the total, the disease control rate we estimated is near 82%. And response rate, which also composed of minor response and partial response, is near 32%. But there are patients which had already had therapies from the clinical trials, or who had therapies in abroad, like Malaysia, Germany, or Australia, and who again got salvage therapy in Korea. So when excluding that salvage therapy patient, which only the patient who had only got Lutathera from Korea, the disease control rate seems to be higher, and the response rate also seems to be higher in this group. And from here, who had ended up the 4th cycle of the therapy, it seems the response rate to be promising for the therapeutic option for these neuroendocrine treatment patients. And this is some preliminary result of the spider plot, and there seems to be some sustained, but we need more longer follow-up to evaluate the efficacy of this PRRT therapy in Korean patients. And we have seen the most common grade 3 or more side effects we have seen were related with hematotoxicities. So most oftenly seen was the thrombocytopenia, and neutropenia and lymphopenia. And for the total patient, we have seen 16.7% of patients have such a grade 3 or more. Actually, grade 3 hematotoxicity, and from one patient, we observed MDS in one patient. But when we see the patient who only had Lutathera without like salvage condition, there seems to be the toxicity seems to be relatively lower. So, and it seems to be similar to the results from other retrospective or prospective clinical trials. Okay, so these are the contents that I want to discuss today. And for the first is about the patient selection. However, in Korea, actually, it is very, it is very affected by the insurance, the national insurance coverage and how the drug, the Lutathera drug was approved. So first, what the drug, how the Lutathera is approved in Korea is the indication is stated like somatostatin receptor positive gastroenteropancreatic neuroendocrine tumors. So in the GEP-NET patients, the Korean FDA have approved. However, the insurance coverage is smaller than this approval. So these get the gastroenteropancreatic neuroendocrine tumors are approved by the KFDA. However, right now the insurance coverage is smaller. And the insurance coverage is only to the patient with grade 1 or grade 2 GEP-NET patient. With for the pancreatic NET cancer, the drug is after it's the level, the drug therapeutic level is for like after 3 other kind of chemotherapeutic drugs. And for gastroentero drugs, it is quite in the earlier phase after having 2 other chemotherapeutic agents, and then it can be covered by the insurance. However, like if it is treated more earlier, it is right now non-insured in Korea. And also grade 3 neuroendocrine tumors are not insured in Korea. And others like for after this 4-cycle therapy, if we want to have additional salvage therapy or for the therapy of non-GEP-NET patient, right now it is only possible by the off-label use of this Lutathera drug. And before that, the SSTR positive here meaning is from the somatostatin receptor imaging, there should be a lesion which is higher than the liver, which means a Cronin score higher than 2. And so more specifically, so what is the meaning of this, the force? So what is the meaning of this fourth line therapy is that there should be at least 3 chemotherapy previous to the PRRT. Then it can be insured. And so for the pancreatic, for example, for pancreatic neuroendocrine tumor, if the patient had initially lanreotide and everolimus and sunitinib previously and had a progression or had a very severe toxicity in these therapeutic agents, then this patient can have a insured PRRT therapy. And it also composed of like other cytotoxic chemo agents can be used. And also in Korea, we can use like off-label drug uses such as TEMCAP or lenvatinib trials. And just one, there are recent ongoing trials regarding this lenvatinib, which is the VEGF receptor targeting tyrosine kinase inhibitors. And and it can be used for advanced grade 1-2 GAP NET patient, and it has proven some efficacy. And you can see that overall response for pancreatic NET cancers are higher compared to the gastrointestinal neuroendocrine tumors. However, the suggested progression-free survivals are similar. But it is right now hard to compare what might be better choice for the lenvatinib or everolimus or compared with the PRRT right now. But the results will come out soon regarding what might be the better choice for the earlier treatment. So currently there are not quite evidence what kind of drug can be used for the first line. So to check whether this patient can have an insurance or this cannot have it, this patient is uninsured, or whether this patient can have an off-label use, when the patient comes, we make this kind of checklist to check in what kind of patient, in where the patient can be treated. And nextly, we can use this Lutathera by the off-label use, and which is out of the indication from the Korean FDA. However, because of clinical evidences, we can use it by the off-label use. And there are right now, two indications approved by the Korean FDA. And the first one is that we can treat the patient again after when there is a progression. But there is one condition to be ensured that the patient should have at least 18 months progression-free survival from the initial, so the first cycle of the therapy. Then we can, and after 18 months, if there is a progression, we can give a chance for additional therapy of lutetium dotatate as a salvage therapy. And we also had gotten a off-label use approval for the non-GAP NET patients, such as bronchial NET or like fail or paraganglioma patients. So the evidence, the literal evidence of how these off-label use were approved is based on these literatures. And for this salvage therapy, there was a EJNM paper in 2019 with 181 patients. And from these patients, they also had similar about the salvage therapy that the patient should have a minimal progression-free survival of 18 months from the initial, so the first cycle of the therapy. And from these patients, the salvage therapy had a disease control rate of 75%. However, the toxicity, like bone marrow toxicity and nephrotoxicities, were relatively low. So it had proven the efficacy of salvage therapy in these group of patients. And there are other evidences regarding the efficacy in non-GAP NET patients, such as bronchial carcinoid and paraganglioma and pheochromocytoma. However, the evidence is somewhat different in the clinical situation. So for paraganglioma and pheochromocytoma, the American Neuroendocrine Tumor Society and the SNM actually recommends, gives a higher evidence to treat the patient who has a MIBG negative. And it seems because it can be there, the MIBG therapy can be a first option for these MIBG positive patients. And for the bronchial carcinoid, currently there is no evidence whether the everolimus is good or the PRRT is good for a bronchial carcinoid. But however, it is recommended after the everolimus to treat, but for the before everolimus, there is currently lack of evidence. But regarding the expense, currently the level of evidence seems to be lower, but there is a ongoing clinical trial to see in this bronchial carcinoid tumors whether to compare this everolimus versus the PRRT. And for the unknown primary tumors, unknown primary neuroendocrine tumors, actually these unknown primary tumors are mostly composed of GI origin tumors. So the effect and prognosis seem to be similar with the mid-gut neuroendocrine tumor. So it can give more higher evidence for the treatment. But currently, these are not approved in Korea, and we can only treat this patient off-label. And there are also ongoing prospective investigations and clinical trials to see whether these PRRTs are effective in other non-GAP NET patients. So I think in the future, we can gather up the evidences and we can have a chance to expand our indication for the therapy. So as I told, there are trials to compare PRRT versus other targeted drugs or the cytotoxic chemotherapy. So we can give it more in the earlier line, like first or second or third line of therapies. And from the NETTER-2 or NETTER-P and other clinical trials, as I have shown for the non-GAP NET patient, we can actually expand the indication not only to the grade 1, 2 GAP NET, but more and other more severe, more extreme stage like grade 3. And there actually has been a clinical retrospective multicenter trial reported in this year, and comparing for the this was a patient who had progression after the somatostatin analog therapy, and compared to the conventional chemotherapy and targeted therapy, there was a gain benefit using the PRRT when it was used upfront. So we expect that this treatment can be used for more for the upfront and expand the indication in the future. And again, however, there are still some concerns of lack of evidences. So in Korea right now, the insurance coverage is very, very small indication. But for the non-insured or off-label use, we have to concern about when or what kind of patient will have a benefit compared with other treatment options. So then what we need is whether there is a predictive marker for this treatment response. However, unfortunately, currently there are no definite predictive factors for the PRRT for this lutetium dotatate therapy in neuroendocrine tumors. Actually, most of these clinical status or biomarkers are rather prognostic factors, but they have little evidence for the predictive of the therapeutic response. And the somatostatin receptor expression also can be a prognostic, but it is currently used as an inclusion criteria. But the predictive role of this expression level is quite controversial because, as you can see from these studies, it is shown that the patient with the response has a statistically higher SUV max values. However, there are many patients who have overlapping SUV max. So if you give a threshold of like SUV max higher than 16.5, it has a higher sensitivity, but the specificity is very low, which means that although it's higher than 16.5, these patients, we cannot be sure that these patients might have a therapeutic effect. But in the other hand, if we give more higher threshold, we can choose the patient who will have the definite response. However, in this case, we can lose all these patients under like more than 33% of patients who will be benefited by this therapy. So this SSTR is just a condition which should be used as an inclusion criteria, not a predictive biomarker. So currently there are some attempts to see whether there can be other biomarkers such as genomic signatures from the blood. So this PRRT prediction question, this PPQ made by like European group has shown that it can have more accuracy compared to other biomarkers to predict the therapeutic response of the PRRT. So if there are more accumulation of the evidences, we might be able to use these biomarkers to select the patient who will have a gain after the PRRT therapy more easily. However, the more important part for the patient selection is to have a multidisciplinary team approach for these neuroendocrine tumor patients. So from the review, it has shown that when we do a multidisciplinary approach, it can change actually the diagnosis and also the management of the neuroendocrine tumor patient. So it is very important to keep discussing with our oncology department or surgeons what kind of therapy should be the best option in the certain patients. Okay, so this was the part for the patient selection. And I think also in the countries which are preparing for the establishment or who are right now ongoing, and there should be some consideration about the insurance coverage, and it might be an issue for patients because these drugs are might be quite expensive without such an insurance. And next is about the pre-therapeutic considerations. And when the patient is selected, now the patient should come to our outpatient clinic, and then we get firstly, we get the informed consent. And most of the content in the informed consent for the patient are similar to the normal chemotherapy, or it is also similar to the informed consent of the iodine 131 therapy. However, there are some parts that can be very important for this radioligand therapy compared to other chemotherapy, because this Lutathera or radioligand therapy is a radiopharmaceutical, and due to the nature of the radioactive isotope, it has a half-life and it can decay. So if there is a delay, it cannot be used and has no choice but to it should be discarded. So, and the cancellation in Korea right now, we get the, we have to order before 2 weeks, at least 2 weeks prior to the therapy. And we get the drug by the airplane. So the cancellation should be done only at least 2 weeks before the therapy. So the important content that we put into the informed consent is that, like, this kind of content should be included. That patient should know that if there is a reason by the patient for the delay, the patient shall bear the entire cost. And we actually tells the patient to write down the date, which is 2 weeks prior to the therapy, which is the due date for the cancellation. Okay, so the problems that we have actually encountered for the delivery, or was like, there are many problems have been encountered, like there are like freighter shipments are not, like it had not been allowed in Spain for some days, and like it cannot be, these radiopharmaceuticals cannot be shifted with like animals. So if there are animals that we can, the drugs cannot be delivered in the same plane, so it can be delayed. And like in our Korean airport, there had been some problems, and there are also problems regarding like coronavirus and like due to the war in Russia right now. And so these all had made a like the problems that we have encountered. And so there should be always a need for a backup plan for such a problem and delays. And next, before we need to check, after the informed consent, we need to check about whether this patient can be enrolled to the therapy. And it is based on the pre-therapeutic lab findings, because if the baseline lab finding is low, there is a significantly higher chance of patient to have toxicity from the therapy. So in the American Neuroendocrine and SNM guidelines, these are some recommended laboratory threshold levels for the like hemoglobin or WBC and platelet and GFR levels. And also there should be a patient preparation regarding the stopping of the somatostatin analog. However, there is a controversy whether this somatostatin analog has a will lower the uptake of the Lutathera, or whether there is no effect. Or also there is some articles that show that when using the somatostatin analog, it can actually enhance the tumor uptake and lower the normal organ uptake. So it is still controversy about using the analog, but in the Lutathera label, it recommends to stop the short-acting somatostatin analog 24 hours before the Lutathera therapy, and for the long-acting somatostatin analog before 4 weeks before the treatment. Okay, so now the patients are prepared, and we have ordered the drug 2 weeks prior to the therapy. And now we have to prepare for the treatment. And these are some equipments that are needed. And this was equipment that are used in the Loyal Free Hospital in UK. And we have visited in 2019 to get information on what kind of equipments are needed for the PRRT therapy. And like some things can be different because we are currently not using a gravity method. So like long needle, short needle might not be needed. So when we were in this, when our technologist, chief technologist Jung Jin-im visited Gloria Free Hospital, he checked out what kind of materials that we have and we don't have currently in the Seoul National University. So with this kind of a list up, we could have prepared what should be prepared for our institute. And the most important instruments currently that we think are this, we need some cart, which is composed of all these equipment inside, and which can be also used for the delivery of the drug to the therapy room. And L block and Acker showed is needed. And these are some other additional equipments that should be prepared before the treatment. So when these equipment are ready, now we can treat the patient. And these are some brief scheme of the timeline for the treatment protocol. And before the Lutathera and lutetium dotatate therapy, 1 hour before we give a antiemetics. And since this lutetium dotatate are given with accompanied by the amino acid infusion, and if it is given at a high speed, there can be a side effect of a nausea and vomiting. So we give a antiemetics and we give actually ondansetron for this therapy. And 30 minutes prior to the therapy, we give amino acid solution, which is composed of lysine and arginine, and it is a ready-made product named as Lisapir, which is given by the Novartis. And then we give the lutetium dotatate. And we actually give by intravenous injection over like 30 minutes to follow the Lutathera label. And currently there seems to be like different suggested methods, and they have like pros and cons. So for the gravity method, which is the firstly suggested method in the label also, is beneficial because it directly keeps the needle into the biar. So we don't have an extra radiation exposure. And because it directly put the needle in the biar, it also may have low residual volume. However, what we actually encountered using this protocol was that there was, without the blockage of the IV line or patient vessel, there was still a patency problem because of we are not sure, but we had a problem for the patency. So as a result, we had to do manual injection. So there has been a chance for higher actually radiation exposure. So currently we have changed it to like pump method, but because we have to pull out the Lutathera using the syringe, there can be some extra radiation exposure for the technician. However, it is easy, and for up to now, we didn't have any kind of a patency problem using the syringe pump method. So what we prepare before the treatment is, firstly, we deliver the drug from our technician room to the treatment room. And we get 2 IV lines, one for amino acid and one for the therapy. However, like you can also, it is also informed that these amino acids can be also infused through the same line. And also if the patient have a central line, these amino acids can be given through the central line. And whenever the patients are ready, we can start the injection. So I'd like to share some brief video of how we are doing it. So as you can see, firstly, this is a normal cell line, firstly. So we check the patency of this line first. And then, so we check the line patency with the normal cell line first. And then there is the drug is actually here. So yeah. So the drug is in the acrylate, and we put the drug now. And then we set up this syringe into the pump. And then we set up the speed to give this volume slowly, as long as at least more than to give it 30 minutes. So, and then after the therapy, what we do is there is a additional line which is connected to the three-way, like seen here. So we have connected a normal cell line bag in by the three-way to use for the flushing. So we regurgitate this normal cell line to the syringe, which had the Lutathera drug, and then we re-infuse it slowly to the patient to make the residual volume as low as possible. And when doing this flushing, like just 2 times, we could have lessen the residual activity up to less than 1%. Okay, so this is a brief scheme of our treatment, how it works. So the importance is we have 2 lines, which has an amino acid bag, and we also give a normal cell line to reduce the volume overall by the amino acid to neutralize and lower the possibility of the nausea and vomiting. And also we give ondansetron 1 hour before the therapy. And there is additional line for the therapeutic agent, and we use a pump method. And we are using 3-way which is connected to the normal cell line, and which is used for the flushing after the injection to minimize the residual activity in this line and also in the syringe. Okay, so this was for the patient, the PRRT protocol, and I think we can have some rest for like 7 minutes, and I think we can go on again. So before, do you have any questions or comments until now? Or are there centers who are preparing for the setup of like lutetium dotatate or lutetium-based treatments? Okay, if not, I think we can have a 7-minute break, and in between the break, if you have any questions, you can just put it in the chat. And okay, let's meet 7 minutes later. Okay, I think we can start the second part. So the second part will be, we will discuss about the issues that we encountered when we do the patient monitoring for the when doing the therapy, and some post-therapeutic considerations. Okay. So This is a case of 43-year-old male patient with a type 1 MEN patient and had a surgical resection. And after this afinitor, sutan, and raneltide, the patient had a progression of the metastasis. So actually, this patient was enrolled for not Lutathera, but a clinical trial of the clinical trial for non-GAP NET patient. And after the end of the injection, when we displaced the needle, the injection site from the patient hand, we found there was a erythema without edema or pain. However, because of the erythema, we directly wanted to know whether there was some extravasation from the injection site. And so we directly imaged the patient, like this is a 30-minute after the end of the injection. And we found out there was a small amount of, some amount of extravasation. And it was slightly higher than like 2.5% ID were extravasated as calculated, normalized from the whole body count. And then, so what we have done was to do the local massage and elevate the arm for a while. And we also did a follow-up imaging for 4-hour and 24-hour and more. And then what we have found was that these extravasated particles, the drugs were diluted and redistributed fastly, and then it was eliminated from the injection site. So what do we have to do when we encounter such extravasation? But before that, the more important is that to prevent and detect. So for the prevention, as we have seen in the video, that we always check the line patency before injection. And when we do the injection, we always look to the injection site to see whether there is a erythema or edema or pain. And we recall for the patient to tell us whether he feels a abnormality in the injection site. And when it happens and when we detect this extravasation, what we have to do for the chemotherapeutic agents, there are two main ways for dealing with the extravasation. One is to localize and neutralize, and these are agents like antibiotics and alkylating agents. However, there are chemotherapeutics which need to disperse and dilute, and radioligand drugs are also included to disperse it as fast as possible. So what we need to do is keep a warm pack and do a massage and compression, and elevation can be done. And moreover, the important thing is regarding this small peptide, this small agent, compared to the antibiotic, this antibody agent, like which is used for like Zevalin. These lutetium dotatate or lutetium PSMA agents are relatively have a very fast redistribution, although there is a large amount of extravasation. So as you can see in this case, the effective half-life of the extravasated the mean was about like 2.26 hours. So it is relatively fastly redistributed. And one another point is that although there is this high amount of extravasation, there is no significant change in the tumor absorbed dose, or there is no significant change of the normal organ distribution or absorbed dose. So the important thing is that we need to detect the extravasation, and if we do the dilute and disperse correctly, these drugs are very rapidly redistributed and there is no significant change in the tumor dose. And the next is about a case of 57-year-old female patient which had a rectal neuroendocrine tumor. And she had a symptom of facial flushing and diarrhea. And because of some progression after the targeted therapy, she had underwent Lutathera therapy. However, at the therapy, what we have encountered was that she had a symptom of flushing after 4 hours of therapy. And after 5 hours, she had a diarrhea and redness. So we have given the penelamine and hydrocortisone to treat the allergic reactions. And after 6 hours post-therapy, the symptom was relieved. So such in cases, we can frequently encounter a patient who argues with carcinoid syndrome in this neuroendocrine tumor patient, like which have a symptoms of flushing, diarrhea, bronchospasm, and hypotension. And if this symptoms get worse and life-threatening, it is called a carcinoid crisis. And it is reported to be occurred in less than 1% of patients, and it usually comes within 24 hours following the initial dose. So we need to actually, the important thing is before happening, we can prevent. And to prevent, we need to know what are the risk factors and what are the patients are in risk for such a carcinoid crisis. And normally it is known that patient which has a previous carcinoid syndrome, and especially who had a flare of the symptoms after the therapy, and who has a elevated tumor markers or high tumor burden, especially in the hepatic, extensive hepatic metastasis patient is in risk of having carcinoid crisis after the PRRT therapy. So what we can attempt is we can correct the malnutrition or high dehydration and electrolyte imbalance. We can control it to prevent. And if it is possible, we can reduce the tumor burden like by surgery or TACE or TARE therapy, local therapies. And co-admission of somatostatin analog can be helpful. And in such a high-risk patient, pre-medication also can be helpful, such as corticoid treatment, antiemetics, and somatostatin analog. But if it happens, the management plan is up to the symptom control. So according to the symptom, you can give, like for the flushing, you can give antihistamine, and like if bronchospasm comes, you can give a corticoid steroid therapy. But if we encounter a crisis, we have to consider ICU and we have to stop the infusion if it is ongoing. And it is needed to give like short-acting octreotide to the treatment. And like MIBG therapy, there is a chance of the tumor lysis syndrome, especially in patients with pheochromocytoma and paraganglioma. And actually, it usually comes after 2 or 4 days following the initial therapy. So actually, in the precaution for the patient after discharge, we give such a content in the precaution for the patient to be assured of like such symptoms if these symptoms develop, and if these symptoms get worse and like shortness of breath occurs, to visit emergency room. And the risk factor of tumor lysis syndrome is similar to the what we have learned from the MIBG therapy, and large tumor size and previously uncontrolled blood pressure and high catecholamine level can be a very risk factor. And so patient with say such a risk factor, we can give the PRRT using a very slow infusion, like over 2 hours. And if we encounter, we have to manage by the symptoms, and also always we have to consider about the ICU. Okay, and the last part is about the post-therapeutic considerations. So first, we do the post-therapeutic scan. And in our hospital, actually the purpose is to check the distribution of the drug and whether it is properly injected and whether there is no other actually we test like for the clinical trial drugs, we test the radiotherapy for the purity. And after treatment, we also check this kind of post-therapeutic scan. And also it can give some hint of like disease progression or disease status. So for this kind of purpose, we do the image after like 4 to 24 hours after the injection. However, you need to be know that when we do a single point imaging at this time point, actually it is not adequate for the purpose of the dosimetry. So like for if you are actually planning to do the dosimetry, you might need to concern. And currently the guidelines actually recommends that there is at least more than 3 or 4 times of multi-time point imaging and up to like 2 to 3 times of effective half-life. So 4 to 6 days after. But however, it is very burdensome to do it in the real clinical situation. So people have found out that single time point imaging can be feasible, and it is very comparable to such multi-time point imaging. And what they suggest is, but it still needs some enough days after the therapy. So people recommend like 4 days after single imaging, 4 days after the treatment is reliable to estimate to do the dosimetry. Okay, so yeah, so you can, if you are considering of doing the dosimetry and for the clinical efficacy, such a single time point can be considered as an option. And to do, and also what we are doing is we always check the post-therapeutic dose rate. And actually, so these parts are important. So we check before the patient discharge, what are the dose rate from the patient. And these data, where we use these data are to actually estimate to establish our institute patient release criteria. And currently the ICRP and in this US nuclear regulatory and also in Korea recommends the dose limit of 5 millisievert. 5 millisievert provides an adequate protection. So patient released from the hospital should have at least a dose rate or dose that will have a less effect than 5 millisievert to the caregivers. So we have, it is recommended that patients should have a dose rate and dose that is lower than the 5 millisievert to others. But also in case of like coworkers and children in the family, the coworkers are like ordinary, like general population. So it should be more strict, like to limit as a 1 millisievert. And also for the children, it is similar. But for the caregivers, like the regulatories can recommend at least for the 5 millisievert. So these have been recommended for the iodine 131 therapy. So we like the regulation and the dose rate threshold for the release of the patient are calculated based on this kind of regulation. And still, because the lutetium has a shorter half-life, and because of a low portion of the gamma, so it is usually the precaution or the isolation of the patient is not necessary compared with the iodine 131. So usually we can do the patient in outpatient conditions. In Seoul National University, actually we do a inpatient-based therapy for Lutathera. However, patients come to the hospital the day before the therapy, and at the day of the therapy, they do the therapy at the morning. And after 4 hours of the amino acid infusion, and then we do the imaging 4 to 5 hours after the injection, and then they discharge. So usually 6 hours later after the injection, the patients discharge in our clinical setting. So these are some recommendations of the American Neuroendocrine Tumor and SNMI guideline to like 3 days for sleep, urination, and general recommendation to be followed, to have like distance or to be careful of urination and to sleep separate for 3 days. And they also commented that there should be a precaution for the young children and pregnant women. But these are from the recommendations of these other guidelines. But we also wanted to make our own guideline, or what are our data. So the data that is needed to know the dose for the caregivers or other like nearby people from the patient. This is the equation that should be calculated. And these three are the facts that we need to know. So for the dose rate, we are checking the dose rate at the discharge every time from the patient. And here, the maximum the mean dose rate was 20.1, but the maximum was 52.1 microsievert per hour. So as like protection should be recommended conservatively, we have calculated those by this maximum value, 552.1. And then we can calculate the time activity curve. And we don't have that much data of the time activity curve of every patient. So we have used a time activity curve from this EJNMI physics paper, which have done a Lutathera treatment. And then we have used for the conservative manner, we use the slow excretion curve and to calculate the time activity curve. So from the 6-hour point, we have counted the time activity curve. So now we have the dose rate and the area under curve of the time activity curve. So now what we need to know is the occupancy factor for each situation. And the exact meaning of this occupancy factor you can easily understand that from this example. So it is 1 if someone is in the patient at a distance of 1 meter and a time period of 24 hours. So, okay, so again, so this occupancy factor is 1 if it is 1 meter and 24 hours. So if it is reduced to 8 hours, the occupancy factor at 1 meter, occupancy factor is 3.1. And then like for the partners, you can see from this extent, if the partner is in 6 hours for 1 meter, it is 4.1. However, if the partner is sleeping together, you can see for 8 hours, it is 3.1. However, the distance is more closer than 1 meter. And distance we have to be multiplied. So it is 100 times more. So if we calculate this, the occupancy factor is like 100 times more. So as you can see, the importance of for the precaution of the patient is not, the more importance is not actually the time, but actually the distance from the patient. So for like, also it is also same for the iodine therapy. So if a patient, for the precaution of the patient after discharge, what we need to emphasize is that the patient should have a very long distance from the like other like caregivers after the therapy. So from our data, we have calculated the AUC from 6 hours, which was 77.6. And from the starting dose of this dose rate, then the occupancy factor for the office colleague was calculated as in the first, as from here. And then the calculated dose for the colleague was 1.36. And our goal was to reduce it for 1.0 millisievert. And so if the patient have a precaution for 3 days, then the targeted, the dose will be reduced to 0.8 millisievert. So we can give a patient to have a precaution at least for 3 days to be in the office. And for the partners, actually we counted the sleeping distance to be like 0.3 meter. I'm not married yet, but I'm not sure whether this might be 0.1 meter, might be very close. So actually we counted it as a 0.3 meter for 8 hours and daytime for 1 meter for 6 hours. And the occupancy factor was 3.95. So the estimated dose when the patient was discharged at 6 hours was 16.2 millisievert. However, the goal is 5 millisievert. So if we give more, like 7 days of precaution, we can reduce the area under curve to 23.1 hours, which is reduced. So the dose is reduced to 4.8 hours. So we recommend the partners to have a separate sleep at least 7 days, which is comparable to the SNM or American neuroendocrine tumor guidelines. So these are some precautions that we give to the patient at their discharge. And actually, when it is calculated, there should be more precaution for the children and like pregnant women when they are sleeping together. Okay, so these are some precautions, right? Example of precaution right now we are giving to the patient. But there is one concern that should be posted, that actually this is calculated based on that it is to reduce it 5 millisievert per cycle. But however, these recommendations are actually largely based on the iodine 131 therapy, which is given like 6 to 12-month cycle. However, currently introduced radioligand therapy are more frequently given. Like for Lutathera, it is given 4 cycles by 8-week period. But for PSMA, it is given like 4 to 6 cycles in 6-week period. So like many cycles are given within a year. So there might be a more, although it is a lutetium-based treatment, we might need to take more concern to have a more strict criteria for, or more, give more caution to the patients. And the next part is about the toxicity that might be encountered. However, the critical organ right now for the PRRT is to be known as a kidney. However, in the most retrospective or prospective study, and in our institute also, we haven't seen a severe nephrotoxicity, like more than grade 3 toxicity in the PRRT therapy group. And it is known to be less than 1%. And especially it is comparable to the Ethereum-based therapeutic agents. So lutetium-based therapeutic agents have a shorter range of radio energy emission. So it may have less toxicity to the kidney. And generally, it is recommended for the patient to have more than GFR of 50 cc per hour. However, it is still tolerable for patients who have 30 to 50 cc per hour. And for these patients, actually, like no dose adjustment is recommended. However, if the patient have a renal impairment, they may have a greater risk of toxicity. So we need to have more intense lab follow-up for these patients. And because hydronephrosis is indicating that there can be an obstruction and there can be a severe delay of the excretion of the drugs and give a tubular toxicity. So there need a additional caution if the patient have a hydronephrosis. And the more frequently seen toxicity, like severe, which is higher than grade 3, are hematotoxicities. And myelosuppressions are, from the previous article, are near like 10%. And more severe form of myelodysplastic syndromes have an instance known to be 1 to 3%. And the development was after the like 28 months after the therapy. And somewhat the percentage are different among the studies, somewhat different, and the recovery time is quite different. However, it is different because of the eligibility, like inclusion criteria maybe, and the number of cycles. So this NETTER-1 trial is the most strict criteria and had only strict protocol of 4 cycles. However, like retrospective study, there are patients who had like more cycles of therapy. So it cannot be directly compared, but we can guess that there are less than 10%, but quite frequent myelosuppression after the therapy. However, these hematotoxicities are quite transient. And the risk factors that are known are the commonly known risk factors are the baseline cytopenia. But the other factors are relatively controversial or different by the studies, but we might need to know that these can affect. So if the patient have low renal function or high tumor burden or like age of more than 70 years, we might need to be careful for the follow-up, whether because these patients might have a incidence of myelosuppression. But the management of myelosuppression is actually, because it is transient, we actually do just wait and see. But in a severe symptomatic cases, we can transfuse, or for the myelodysplastic syndrome, we transfer to the oncology hematology department for the treatment of such a symptoms. And one more thing is that from as treating these neuroendocrine tumor patients, we now have a chance to get a call from the emergency department, and there are our patients who are coming to the emergency hospitals, and the common causes were like bowel. So we had 2 to 3 cases of emergency department call, and major was for us was the biliary obstruction. But what we can encounter are like bowel obstruction and neutropenic fever and tumor bleeding of the patient. And for the bowel obstruction, it is known that in the NETTER-1 trial, it was reported to be near 1%. However, in patients with mesentery or peritoneal seedings, the incidence can be higher, like 5 to 6%. And however, these obstructions are mainly, the cause is due to the therapy-related inflammation. So the management can be done by the steroid treatment. So, okay, these are some summary of the follow-up schedule of our patient. So after the cycle, 4 to 6 weeks, we do a lab, the OPD follow-up with the lab, and we order the drug if the patient is possible for the second therapy. And then after the second therapy, we do the lab and imaging. And then after the 4th cycle, we do the lab and imaging at 4 to 6 weeks. And after that, we actually normally regularly follow up by 2 to 3 months for the patient with the imaging. And after like 1 year, we can refer again to the department, which was primarily doing the treatment of the patient, like to the oncology department, oncologist again. And these are some guideline recommended follow-up protocol and it also similar. So lab tests will be more frequently done, and we can do imaging for like 3-month period and more. After like 6 months, you can do like more prolonged period. And then after the follow-up for 1 year, you can refer again to the primary team, like for the oncologist. And right now, the recommended diagnostic imaging agent is CT or MRI, but not the somatostatin receptor imaging agents such as gallium dotatate PET. And since it is known that this somatostatin receptor expression does not always, because it does not always mean response, it can be a therapeutic effect. However, it can be due to a disease progression, and because getting bigger, the expression can be seen lower, or there can be a change in perfusion after the therapy, or the dedifferentiation can affect the expression. So these dotatate to be used as a response evaluation is very limited and controversy for now. However, CT and MRI is also has known to have a limited usage, because it like these kind of direct therapies cannot directly have a anatomical decrease of the size. So like stable disease may not be like responding patient may not be seen in the earlier time points using CT or MRI. So there has been an attempt using a blood-based biomarkers. However, chromogranin A or like other biomarkers have been like less limited, very limited efficacy for discriminating the responder vs non-responder. However, like currently the blood-based genetic biomarkers like NET-test, which was developed in European research groups, and these are indicator of the tumor burden, and using this NET-test, they have seen that it can discriminate the patient like non-responder from the responder more effectively compared to the other like biomarkers readily used in the clinics. Okay, so for the summary, we have discussed about some practical issues of the setup and establishment of the PRRT. And I wanted to share our experience in Seoul National University Hospital. And then, so for the patient selection, it is actually in Korea more up to the insurance indication right now, but for the selection, the most important part is the multidisciplinary approach. And there are many clinical trials, ongoing trials that will give some more evidences that we might expand the indication of this PRRT therapy. And for the pre-therapeutic consideration, there should be a statement regarding the disposal in the informed consent, because there is a many chance of problems encountered for the delivery or delay of the drug. And for the patient monitoring, the prevention and detection of the extravasation is the most important. And if it happens, the key management is to disperse and dilute. And for the carcinoid crisis, the important thing is to stratify the patient in risk and to prevent the happening of this crisis. And finally, for the post-therapeutic considerations, renal toxicities are relatively rare, although it is the critical organ. And the hematotoxicity are more frequent, but however, they are like transient. So we can wait and see for the patient to be recovered from such a myelosuppression. Okay, this is end of my presentation. So do you have any questions or comments? And I think there is one question from the chat. No, actually, we do not do like very early imaging to find out the extravasation, but we do like in certain case, whether we see a symptoms of or like symptoms of extravasation, such as erythema or like redness or edema or pain. So in this case, we do like directly after the injection, we send the patient to the imaging gamma camera and then image to detect the extravasation. But normally we do an image at 4 to 24 hours post therapy to just see the distribution. But it has no purpose of doing dosimetry. Okay, and would there be some other questions or comments? Or if someone can share, if there is a plan or ongoing attempt for establishing the such nutrition-based therapy, it might be great if someone can also give some experience or if we can have another session next semester to discuss about such things. Okay, and I think there is our student who is listening, Dr. Jinsil Kim, maybe. Do you have any questions or comments?
No.
Okay. Oh, just what for the Dr. Handra's question, we only do once. Actually, we are concerning to do 4-day imaging also, but it is still if we do the post-therapeutic scan at 4 days after, the patient have to come again. So it is quite hard. And actually in Korea, imaging of the lutetion scan is not paid or covered by the insurance, or it is not actually approved protocol. So that is also some concern. We cannot get paid for the imaging, post-therapeutic scan imaging. So we have some limitation of doing those post-therapeutic scans right now. But if you want to collect the data and to do the purpose of the dosimetry, I actually recommend it might be better to do the imaging at 4 days after the therapy using the SPECT. And the SPECT FOB might be enough to be covered from the liver tip to maybe the pelvis level might be enough for the purpose of dosimetry, since our interest of organs are like livers, and source organs might be liver, spleen, and kidneys. Okay, thank you again for all your participation. And yeah. Okay, so I think we can meet everyone again next week. And next week, Professor Edmund Kim will give us a lecture. Okay, thank you very much and see you next week.
Yeah.